Dr. Rahul Bhatia, who is a vitreoretina consultant at Sharp Sight Eye Center, Delhi.
Good morning all. I would like to thank AIOS and APO for this opportunity. I will be discussing about the latest clinical trials in RVOs. We'll explore the evolution of treatment from laser therapy to latest anti-VEGFs. Let's begin. I have no financial interest. The introduction we have already seen. The treatment guidelines gives us a broad overview of the evolution in treatment. We started from laser photocoagulation to now anti-VEGFs to now newer agents for BRVO. The BVOS study was a landmark trial that assessed the effectiveness of laser photocoagulation in BRVO. The study aimed to determine whether scattered laser prevented neovascularization and if grid laser improved macular edema. This was a well-designed randomized controlled trial with a 3-year follow-up. The patients were divided into observation and laser photocoagulation groups. Importantly, inclusion criteria required vision worse than 20 by 40 and edema persisting more than 3 months. The criteria that might feel outdated today. The findings were clear. About 1/3 of the patients showed spontaneous improvement early on, but laser treatment significantly improved visual outcomes compared to observation. The gain in visual acuity was over 1 line more than the laser group by the end of 3 years. Despite being foundational, the BVOS study had several limitations. The patient selection was narrow, the treatment was delayed, and modern diagnostic tools such as OCT was not available at that time. Today, its methodology seems outdated, but its historical significance remained. Now we come to trials for steroids. The SCORE BRVO trial investigated whether intravitreal triamcinolone was superior to laser treatment. The patient was randomized into 3 groups, 1 mg, 4 mg IVT, and standard laser treatment. The study found that no significant visual benefit of IVT over laser. However, steroid had a higher rate of cataracts and IOP elevation, particularly at 4 mg higher dose. Thus, laser therapy remained the standard treatment for the time being. The Geneva trial assessed dexamethasone intravitreal implant for macular edema in BRVO and CRVO. More BRVO patients gained more than 15 letters with dex rather than sham group. However, the adverse effect was similar to the triamcinolone group. Now we come to trials for ranibizumab. Bravo was a pivotal trial assessing ranibizumab in BRVO. It included 397 patients randomized into 0.3, 0.5 and sham injection groups. The primary endpoint was more than 15 letter gain in BCVA. Ranibizumab significantly improved vision compared to sham. The 0.5 mg dose showed slightly better outcomes than 0.3 mg. Additionally, fewer patients required laser treatment in ranibizumab group. These are some of the extensions of Bravo study with long-term follow periods. These long-term studies established that BRVO had a chronic component and required multiple injections and continued monitoring. Now we come to aflibercept. The Vibrant study investigated aflibercept for BRVO and found that it improved vision outcomes with extended durability compared to laser photocoagulation. The Copernicus and Galileo trial examined aflibercept for CRVO. The patient gained 17 to 18 letters at 6 months, confirming aflibercept as a potent treatment alternative. Now we come to newer drugs which are available. Brolucizumab is a next generation anti-VEGF agent, offers longer durability with dose intervals up to 12 weeks. However, few patients have shown higher risk of inflammation. Kite trial was a multicentral trial comparing brolucizumab with aflibercept. It showed non-inferior visual gains compared to aflibercept, with more patients achieving extended dosing. Macular thickness reduction was greater with brolucizumab. However, intraocular inflammation were reported. And these are some of the other trials of brolucizumab in RVOs. They established similar visual gains and fewer injections as compared to other anti-VEGF agents. Now we come to faricimab. It is a bispecific antibody targeting VEGF-A and ANG2 receptors. It stabilizes vessels better than standard anti-VEGFs. The trials are underway for its efficacy in BRVO and CRVO. These are some of the trials which are available. The results showed comparable visual gains but better fluid control with faricimab, reducing injection burdens. Balaton trial is a multicentral trial, double mask comparing faricimab with aflibercept for BRVO. The faricimab achieves similar visual gains as compared to aflibercept, with more patient extending beyond 12 weeks dosing. and it may provide faricimab provides better vascular stability and safety profile is comparable to aflibercept. This Comino trial was for CRVO, and the results were similar as in the Balaton trial. Then we have new drug in town, aflibercept HD. The CAUSAR study examined an 8 mg aflibercept dose in RVO. It demonstrated significant visual gains at 36 weeks with longer duration, longer treatment duration. The safety profile was well tolerated, and it had comparable efficacy as compared to 2 mg aflibercept. Then we come to biosimilars. There are multiple trials with biosimilar. With the most important one was Razumab, the Caesar study. It showed a significant improvement in CDVA, improvement observed as early as first month, and it was comparable with the original ranibizumab injection. Then this is another one from Reliance. This is Ranizumab Razor study. It was comparable to ranibizumab, the original molecule. Then these are some of the trials which are under trial for aflibercept. There is some trial with Samsung. There is some trial with Bioic, and we can see much more number of biosimilars for aflibercept after some times. Over the years, clinical trials have refined our understanding of RVOs, from laser therapy to anti-VEGF agents and emerging therapy like faricimab. Our approach continues to evolve. The future research will further improve patient outcome, especially with gene therapies around the corner and with longer lasting treatment and personalized medicine. Thank you.
I would now request, thank you, Dr. Rahul.